So that should raise a lot of questions. Selective facilitation, a bit like selective primary health care. Questions, we have 10 minutes. Please go ahead, introduce yourself.
Yes, so I have a question regarding the rights dimension, rights approach to healthcare. Now, I had a student, and he's now working at the LSE, Daniel Wang from Brazil, law and philosophy student, and he documented, as you might know, that in Brazil there was the law guarantees equal health. They have a right to health, not health care, but to health. And this led to very perverse and poor decision-making because he documents many decisions that went even up to the Supreme Court where individuals, often wealthier individuals, because they had the ability to get the lawyers and take it to court, demanded very expensive cancer treatment, which was not available in the Brazilian system, and in some cases at a cost of several $100,000, were flown to the United States to receive this treatment at a cost to the public health system. And the Supreme Court in those instances pronounced in favor, so the government was denying this coverage. The Supreme Court pronounced in favor of it because they said that the law stating that everyone had an equal right to health and the necessary services for this provided for this. Then after several cases they backed down. They realized they were creating a monster. But his main argument was the following. Look, the legal system is often set up so as to protect the individual against the collective, the rights of the individual against the collective. And in this case, the judges said, these individuals have rights. It's not our business to decide that these rights can be overridden by the general good in these cases, so we must grant these rights. His conclusion was, courts are extremely bad vehicles for making the kinds of prioritization, difficult trade-offs that are necessary in public health, and therefore that, in fact, we should not use a rights-based framework or use the courts to have the enforcement of social rights like the right to health, except in the very minimal sense that there should be a public procedure which is kind of transparent and basically reasonable for the allocation. So courts can be used to say there is no procedure at the public level. But other than that, granting individual rights to particular access, his argument is it's completely the wrong way to go about it. So interested in your response.
Can we maybe just take one more question? Or maybe, because that's a very specific question, we should go ahead.
Hi, good morning. I'm from the, I'm a master's candidate in international health policy and management at the Hela School Brandeis. And I have more of like a comment. I think when it comes to population, I come from Nigeria, and many years ago they declared universal health coverage. And we know it's just for the civil servants and government officials that don't have problems paying for healthcare in the first place. And I think government will do this because that's the easier route to take. The more important, the more disturbing issue is to reach the vulnerable and the poor and those that need this. You need to start from behavioral change. There's a problem with demand, not necessarily supply. There's a problem with supply, but there's a bigger issue with demand because of behaviors and people's perception to what they think they need from the health system. Now, there's also a lot of abuse. I worked with a health insurance company that got a funding from a Dutch NGO to start up a community-based health insurance for this really rural and poor area that had just farmers and petty business market women. And contribution was like $7 for a year. And after some time, we're going in to evaluate, and it was, participation was growing and things are improving. But no, people from outside this community found out that for $7 a year, they could get maternal and child care, they could get all these services, and they didn't qualify to be part of this. And, they came in one way or the other to be part of it. So there is always abuse. So I think for governments that have no accountability and there's a lot of corruption, they'll rather find the easier route, and it's just going to make the universal coverage in their own way. It's just going to benefit the rich, and there's a problem with really covering the poor and the vulnerable, and they will not take that route as long as nobody makes them accountable for what they do. So it's a two-way street. If the citizens don't have a voice and a choice to say and demand that this is what they want, and the government is not accountable, universal coverage is just going to be, for the rich and the wealthy.
Okay, thanks. Alicia, do you want to do the rights framework? Is it on?
Has been quite criticized, and I would point you to Hoffman and Bentis's chapter in, there was a book that came out from Varun Gowrie at the World Bank and Daniel Brinks, Courting Social Justice, and Hoffman and Bentis have a chapter on Brazil in that book. João Biel at Princeton has also worked a lot on health rights litigation in Brazil. I think it's the evidence that individual litigation for healthcare entitlements is in some way, in fact, not theoretically, but in fact, taking money away from broader public health interventions or care that would benefit the needy is very thin, if not non-existent. I think in theory there is a real problem there, and I think it is probably fair to say in Brazil that there's a lot of litigation, by the way. Daniel Wang picks out the very expensive care where they're sent to the United States, but there's a lot of litigation for very, very basic, non-steroidal anti-inflammatory drugs, disposable diapers, very basic things. So I think it's also probably fair to say that the middle class has benefited more than the lower class from that rights league. And that is also not surprising. When there are rights, historically, the middle class benefits first. But under certain circumstances, and I can say this about Colombia because I've worked very closely there, the Brazilian legal system is a little bit different and less likely to issue structural judgments. But in Colombia, the massive amount of health rights litigation, which followed approximately the same pattern as in Brazil, led to this major structural decision by the Constitutional Court, which has created a whole public deliberation about the nature of the health system, the content of the mandatory package, the differentiation between those people who are in the contributory regime and the subsidized regime. There's now an entire process on rewriting legislation for healthcare in Colombia. So I think if you have a notion of democracy that includes deliberative democracy, I think judicial review can actually, under certain circumstances, play quite an important role. We've seen that in some of the Indian cases. We've seen that in the South African cases. So judges are unelected. They may not have the expertise to make these budgetary allocation decisions, but in some cases, the structural kinds of remedies that they order can actually promote broader deliberation and equity, in my view.
So I'm just going to get 2 more questions here, and then you can come in. Please introduce yourself.
Thank you. My name is Werner Soers. I'm from Institute of Tropical Medicine, Antwerp, Belgium. This is a comment on the plea for selective facilitation. A plea which was not at all surprising, I would say. It is indeed perfectly in line with selective primary health care. The first problem I encounter with it is that it is based on a discourse more than on evidence, a discourse which is a distant dream, because the first element you give, that by saving on insurance for those who are rich, you will have more money for the poor, is totally at odds with the primitive and quite simple insurance logic that the more you collect and the more you pool, the more money you can spend. And there is no realistic reason at all to think that the rich will keep on paying for the poor in that case. And there is historic evidence for that, and that historic evidence is precisely in the case that Alicia just mentioned. After Law 103 in Colombia in South America, you had 2 insurance systems, one for the poor, one for the rich. The insurance system for the rich never came up with more than half of the benefit, for the poor, never came up with more than half of the benefit package of that of the rich, which gave rise to the actual problems. So you end up in your system with a poor insurance for the poor, not a good one.
Good morning, thank you. I am Freywat Brahana from the University of Bergen. I'm an Ethiopian. And thinking of universal coverage, coverage and enrollment and the facilities, choosing the facilities and so on. You know, there are a lot that has been done, like mentioned yesterday by the World Bank presenter. And so there is nothing maybe new. A lot has been done. But we have failed on many things also in the past. And what we need to do at the beginning is to learn from what has been done in the past, which could have been very effective, but where we have failed, and try to cover population that were not covered particularly from the right-based approach, from the effectiveness point of view, like the young people, and working, starting on that for a very low and middle-income countries would really be a great investment. I just want to bring one example at this point. If you know, there was a very big UN-led endeavor, the Population and Family Life Education Endeavor from the 70s, which covered Asian, African, Latin American countries. And the family life education part really focused on sexual reproductive health issues for young people. You see, we have a facility, school, you know, the teaching institutions are ready-made facilities that can be used where we get all young people. If we really effectively address them with a preventive, promotive, and services also, primary health care services, not focusing on small interventions like only family planning. Why not the comprehensive reproductive health package as a whole? And focus on the behaviors like mentioned by the Nigerian just now. Focusing on interventions comprehensively, not to miss opportunities, because we get young people in the schools. If school health services are really addressed with comprehensive services, with preventive, promotive, and services, other services they need, just in the school. Imagine we cover 30, 40% of the population, which could go back home and multiply what we have taught them and really, you know, in a very, very low cost. But we haven't learned this. There is you know, it's a tragedy that we have felt on population and family life education. It was a 16-year program in my country, 4 country programs, UN-led, WHO, TESA is here. We can go and review that process, for example, and we can learn a lot and, you know, be effective and, you know, have good outcomes. So investing on young people is really the biggest investment which can
thank
really be
you.
implicated.
So we'll take one last
Thank you.
question and then back to the speakers.
Thank you very much. My name is Moussa Sako from the National Institute for Research in Public Health in Mali. I think my first question was almost the same as the first speaker about the right to health. I mean, this concept of right to health, how to implement in developing countries, because if you take many African countries, including my country, we have more than 50% illiteracy. I mean, people may not know even the law in their countries and be aware about this human right to health. So how they can be involved to do that, to know that, and at which stage they can conclude that they have been ignored or neglected or have been not done, to complain. I mean, in terms of justice. I mean, this is something. So how people can be aware about that. And the second is the quality of services, which is, I think, very difficult to discuss. But maybe I just want to raise one question: how to assess the quality of service, because it's a very big subject. Everyone wants to know what is the quality of the service in terms of human resources, in terms of diagnosis, in terms of everything in infrastructure. But this depends on the level of the country, poor rural area versus urban areas and so on. So I don't think there is a kind of gold standard for that to assess clearly the benefit of service according to the level of the country. And I think just to finish that, if you have more than 80% of the population living in the rural areas, and they may not be really be, in terms of access to all the facilities, some of the people, 20%, living in the urban areas. Thank you very much.
Okay, so I think I've been told we need to cut. Can I have 30 seconds for each?
All right. So quickly about whether the rich will ever support enough the system if it's elective. I gave the example of Seguro Popular in Mexico, which is, it's not a kind of clear case, but I think closer to my end because if you have insurance from your employer, you don't get it. If you're a private capitalist who doesn't have an employer, so wouldn't have an insurance, otherwise I have been told yesterday by an insider that informally they do not reach out to this kind of crowd, so effectively it's for the poor. What we have seen over the years there is mere expansion, not just in the number of people enrolled, but also it becomes more and more generous over several years. We have examples from either brand. I think there is a tendency for people like myself, like maybe yourself, progressive from America, from Western Europe, where the struggle is often on getting the benefits from universalizing to extend that around the world when we are talking about budgets of $16 a year per patient in Ethiopia. I think the gains from getting something like the leukemia treatment are more important. And I
Thanks a lot, Nir.
Okay.
Alicia.
Okay, in terms of, I guess I'll talk about quality first. I think that's actually a really difficult and complicated question. Not just in terms of standardizing, but also in terms of people's perceptions. And this goes back to what I was saying about consumers versus citizens and having some kind of objective account of value and quality. Because we know from surveys, for example, of women in facilities delivering, that they routinely don't assess the mistreatment and abuse they suffer in the same way as an objective observer would. Recently, an NGO in Dar es Salaam called Twaweza did a survey of health system users. 96% of them reported high satisfaction despite the fact that over 70% had to pay bribes and unofficial payments. So there is that disconnect, and I think that a lot of the subjective indicators being discussed now in the post-2015 context need to be thought about in terms of how do we account for this kind of internalized domination that many sectors of society feel. In terms of the other question, which is a longer answer on what do you do about rights in a very resource-poor setting, that's what I do most of the time with my life. So I work in Tanzania, I work with advocates in Uganda on social mobilization as well as litigation, and have been involved in implementing rights-based approaches, so I'd be happy to talk about that offline.
Okay, thank you. I'm going to ask, let's give a hand.